that bump, you have to know what is normal. So what you have to do is that you have to go to the other eye and feel it first and compare it to this side. And if you feel that this is very, very tight and I can't get it over to the other side, then you got +4. And or if you're just pushing it over and this thing just like goes back and forth like easily, then it's like it's too loose. Then you got -4. Or maybe the tendon is not even there. So in patients with the cerebral palsy, when you do force ductions, you cannot feel this bump as it slides over from one side of the crest to the opposite side of the crest. Okay, does that make sense? So anyway, so that knowledge is extremely critical for you to treat Brown syndrome. Okay, so here's a patient. Sometimes these Brown syndromes can resolve over time because remember that the tendon is under a lot of tension. So by just leaving it there, the tendon can elongate by itself. And so that's why up to 90% of the Brown syndrome, it goes away on its own. And that's why the surgery for Brown syndrome is not that common because we let it go. But in some patients, it does not go away. It can actually last forever. Also, it can be acquired. So this particular patient, so there are many different types of surgical techniques that's available. Whenever you see a lot of options for a particular condition, that means that you don't have a good solution. And this is one of them. And that's why Brown syndrome, people talk about Brown syndrome like, they're like, there's no tomorrow, because we don't really have we don't have a perfect solution for Brown syndrome. So, and cerebral tenotomy, so we just go and simply cut it. The problem with the cerebral tenotomy is that 100% of these patients are going to develop cerebral paresis, fourth or palsy. Okay? So, or sometimes we do split tendon elongation, like a Z-plasty, as you can see here. So we make an incision here and here, and then just let the tendon just rip, and then you place a suture. And this is something that we do for a cerebral weakening procedure for A pattern. And also, Ken Wright developed a silicone band. So like it's a band that's used for retinal detachment surgery. So they cut small portion of it, like either 4 millimeters or 8 millimeters, and you place it. And the problem with this is that you can't, once you put it in, you can't like change it, okay? Because it's permanent. So we developed a surgical suture spacer. So we use a non-absorbable suture, like a Marceline, and we use it as a tool to elongate. And this is what we do. So you identify this pubic tendon, as you can see here, and we make an incision in the supranasal quadrant, and we isolate this pubic tendon, because remember, this pubic tendon is about 10 millimeters posterior to this pure rectus muscle in the nasal quadrant. So you just go in and find it, and it's actually not that difficult. And then once you find it, you can isolate it here, and then you pre-place 2 sutures like this, and then you transect, you cut it. Now you have 2 pieces that are separated, the tendons, the proximal and distal portion, and then you can put a slip knot like this, and so you elongate it by 4 millimeters or 6 millimeters, whatever number that you want, and then you go back and do a force duction test. And what you're trying to do is that you're trying to match the force duction on the opposite eye. You understand? So you go back and forth. Let's say you place 4 millimeters and you compare it to the other side and it feels still too tight. Then you go back and you lengthen it a little bit more to 5 millimeters and 6 millimeters. And then if you go too much, then you're going to realize, whoa, I did too much. Now it's too loose now. Instead of being 0, now it's -2. It's like, I can't feel the bump. I can't feel that crest. You understand? Then you could shorten it again. So you could go back and forth, and it's a try and error. Okay? So, so this is exactly what you end up with. So once you're happy with it, and then you just cut one of the sutures, and then you pull it through the other side, and then you do a permanent suture, like this. And so this is exactly what you end up with. Okay. So we looked at these patients, and we looked at the head postures, and we looked at 19 patients, and this is primary gaze deviation before the surgery, and this is after surgery. So prior to surgery, it was about 10% doctors. It went down to 6%. And then elevations in adduction deficit improved significantly. And then all the other, the head posture, which was the most important, the torticollis, improved in all the patients. And none of the patients have developed any recurrence. So these are the initial patients that we saw with the Brown syndrome. And then 6 months later, we saw this patient, and it just wouldn't go away. It was just still persistent. So we decided to proceed with the surgery. And this is post-op day 1. Okay? And as you can see, the elevation deficit improved just immediately. But it's not perfect though. And this is a post-op 2 weeks. And then this is, as you see, pre-op 2 weeks, 6 months. So it just continues to elongate. So you go for, what you want to do is that you go for a slight undercorrection, and the tendon and then it just gradually lengthens over time. And then 60 months post-op. This is almost 5 years later. Okay. So this is a patient with a 25-year-old with Brown syndrome with the diplopia, and this is 6 months post-op after surgery. So I'm going to just tell you that this is a pretty effective surgery, and we're going to try to do the surgery tomorrow if possible. And if anybody's interested, please come and watch. Any questions? You guys understood all that? Yes.
If I don't want to do a fluorescent on the operating room, because it depends on the ability of the surgeon, any surgeon, do you recommend that 1 millimeter from along superior oblique muscle to fix how many degrees of extraction?
Perfect. Okay, I'm gonna repeat that question, and then so first of all, obviously this is one of those things that you cannot learn just by reading a book or watching YouTube in terms of like what is +1 or -1. So this is where a lot of practice is important. So what you have to do is that you have to do force suctions on all of your patients when you do surgery before you do any surgeries, so you know what's normal. So that's the starting point. Okay. And I am going to tell you, if you start doing force suctions on everybody, you will know what is normal. Number 1. Number 2. When you have cerebral palsy, which by far the most common vertical strabismus. I mean, fourth arm palsy is something if you deal with strabismus, you see it every day. So when you're doing the cerebral palsy cases, so do a force suction so you know what is -1 or -2 feels like. Okay. When you get to -4, that means that there's nothing. You cannot feel anything. Okay. So try to have some reference point, and then and of course when you have patients with a cerebral overaction with the A pattern, again do a force suction so you have some idea of what it feels like. When you get to +4, you cannot, like with any force, you cannot get that tendon from one side of the crest to the opposite side. You cannot do it, okay? Because it's so tight. So that kind of gives you an idea. So the good starting point is usually 4 millimeters. I always tell people start with 4 millimeters. That's always a good starting point, and then you could go ±1. Good question. Any other question? You guys understood all that? Okay. Yes.
compare the degree with the normal eye, the opposite eye is normal. We can compare.
Yes,
the degree.
yeah,
But
that's right.
if the bilateral brow syndrome or bilateral superior oblique overaction, bilateral, so how we.
Sure. Fortunately, like Duane syndrome, bilateral brow syndrome is extremely rare. As a matter of fact, in my career, I specialize in Brown syndromes, and I get patients from all over the country to take care of Brown syndrome. I've only seen it maybe 3 times, so it's extremely rare. Okay, Brown syndrome, Duane syndrome, bilateral cases are pretty rare. Okay, good. Anything else? Okay, next talk. This is actually one of my favorite talks. I give a lot of inspirational talks for doctors because I truly care about our profession. Not just pediatric ophthalmologists, but ophthalmologists. I really want to make sure that I hope to inspire you, and so that you can practice for many years to come and have a successful life. So I want to share a personal story, and after I share the personal story, and I'm going to show you a book that you could read if you like, if you're interested. So I've been doing a medical mission, a global health program for 25 years. I've been in practice for about 25 years. I don't look that old, but I really have been doing it for that quarter of a century. Okay? I don't look like I've been doing it for 25 years, right? I do? Okay. So I'm going to just talk about, we have some medical students here and residents, so I want to just kind of give a bigger picture. Sometimes we are so focused, we ophthalmologists are so focused on what we do, sometimes we forget to see the big picture. And this is something that I like to remind myself, so I want to talk about what is it that we do as a pediatric ophthalmologist, and then how do we do it, and then why do we do it? Okay. So, and some of the challenges and solutions. So, first, as you know, we have, fortunately, 6 muscles on the right and 6 muscles on the left. And each one of those muscles has very unique function. And with the help of these 12 muscles, we can look in different directions with binocularly. And that gives us the stereopsis. There aren't that many animals in the animal kingdom that have this complex ophthalmic system. Please remember I said this. It's actually amazing. We only have 12 cranial nerves. 3 of those 12 cranial nerves is purely devoted for motility. I mean, just think about that, right? I mean, isn't that amazing? We have 12, and 3 of those cranial nerves are purely devoted for motility. So obviously, there has to be some importance why we have these muscles. So these eye muscles, of course, help us to see depth, and then this information gets sent to the back of the brain. And then during development, this is extremely critical, because if any one of you develop problems with any of those 12 muscles, you're going to have double vision. You're going to be miserable. With kids, no, they adapt. Okay? So the LGN, the lateral geniculate nucleus, which is right here. By the way, LGN is the largest nucleus in your entire body. Okay, it's very, very important. And then this is what the normal LGN looks like right here, as you can see, with the 6 nice layers. But with the blurred vision, it atrophies, as we all know. Okay? Having problem in one eye will cause atrophy in both bilateral LGNs. Okay. The good news is that we can reverse that. If we can regain their vision, and we can reverse that atrophy. But unfortunately, the bad news is that if we don't reverse it during the critical period, then it doesn't really matter. So that's why some of the patients that you do cataract surgeries, you put all that effort in, and their vision is still the same, because the amblyopia was there, and you just never knew it. Okay? So here's a patient with esotropia, cataract, and then glaucoma. And then we have various treatments, including patches, glasses, and surgery. Why is this important? Because this all ties to their development, their physical development, which is tied to their academic achievements. So during that very sensitive period, we have to get them to see clearly and binocularly, okay? And that's where the pediatric ophthalmologists come in. And early on, I knew the inequality of care. I really have traveled all over the world. And I've been to 40 programs in 5 continents in the last 25 years. And so I really have practiced and seen a lot in my short life. And I cannot even tell you how many operating rooms that I worked in. So I actually, when I say Dr. Wee, the way he holds his instruments, I could already tell, just like that I know he's a good surgeon. And so I've seen really a lot of things in my short life. And this is where my career started. It was through a flying eye hospital. This was back 25 years ago. As you can see, and you're doing surgeries, and some of you I know have been inside the airplane. So we do surgeries inside the airplane while the people are watching in the back. And why is this important? Because it provides a very safe environment, like here right now. You guys are, we have like very nice, bright doctors that are females here, but in certain cultures, the female doctors are not supposed to talk. So they don't, like, if there's one male in the room, they don't ask questions. So we try to provide a very safe environment. It's like, you know what, this is a safe environment, so they can ask questions. So, it's a very nice environment. And also, I do surgeries in the airplane, not just in the airplane, but also go to the local hospitals. And I work with nurses, I mean, you name it. I've worked with all the different specialists. And when I started this 25 years ago, I thought that this was my image of global health. Like, I thought people would be just very happy to see me. They're smiling. But in reality, it's actually very different. And some of you actually may know this already. In reality, it's very, very different because the expectations from the physicians, the local hosts, the patients are very, very different. And also, always unexpected things happen. Even this program, I really did not know what to expect. And when I first started this, there was no internet. Okay? I didn't have internet. So I didn't even know what to pack. So some of these so a lot of times going through the immigrations, half of the stuff that I packed will get taken away. I mean, just imagine that. And then you get into the vehicle, and then you go through these roads. And so in Bolivia, you're going through the most dangerous roads in the world. The Bolivia, as you know, is the capital is in the highest altitude. They had to do that. Do you know why their capital is so high? They were running away from the Spaniards. The Spanish were trying to conquer Bolivia, and so they didn't want it to be conquered, so they just kept running, and the only place they could go was just up. And that's why their capital is so high. So you could barely breathe there. Okay? And then, this is actually China. Certain places in China, when you think of China, you think of like Beijing and Shanghai. No. 90% of the places are not like that. The roads to the city, there's only one road to get to Inner Mongolia. And if that street is flooded, you gotta go through. There's no other roads. There's no detour. Okay? And then the first day, these are patients waiting. You can see like the patients waiting everywhere. There's patients waiting. And this is the next block. It actually goes into the next block. Just keep on going, and then it just actually goes on, and it goes to the entire block. and after block after block. And you got to see these patients because they've been waiting for you. Okay? And then, so some of the patients that we see are the most difficult patients. And some of the patients that I took care of here actually were some of the most difficult patients that I've seen. So these are, corneal problems, and also, and a lot of times they run from the family. And then this is in Romania, and so we go to the orphanages because they have no health care. So we actually physically go to the orphanages to take care of the children. How many of you seen an orphanage here? Is there an orphanage here in Vietnam? Yes? No? There is? Okay. Well, I'm going to tell you, this is a true story. I went to this place called Bodoshan, right here. It was right next to Ukraine, right there, okay? And this is their major freeway. This is, if you can imagine, that's the freeway, and you see people in horse carriages carrying hay on the freeway, okay? And then, when I went there, they've never seen an Asian person before. So they thought I was Jackie Chan. You laughed. They've never seen a non-white person before. If you can imagine that, right? So I was the only Asian person in the entire city. So, I thought it was funny. So I was very mad because I thought I was better looking than Jackie Chan. And I said, no, I'm younger and better looking than Jackie Chan. So anyway, and then we have to take our equipment with us. And then we have to set these equipment up. And then a lot of the times that we don't have the drawers or anything, so we just tape it to the wall. So different power lenses, we just tape it to the wall. And then we're doing surgery, and as you can see, a lot of times that we don't have air conditioning like here. So it's just hot, if you can imagine. So if you can see my hand right here, I am sweating. I don't have anything, I don't have a gown on even, because it's too hot. And my hands are sweaty. And then we have a fan going on, this huge fan going on while I'm doing surgery. So our 6-0 microsutures will get flown away if you don't hold on to it. So everything you have to put weight on top of it, okay? So it doesn't get flown away. And the gloves, here you have different sizes, but many places around the world there's only one size. If you can imagine that. So if your hands are too small, you just put on 3 or 4 gloves. And if your hands are too big, you better pray that there doesn't rip when you're doing surgery. And then the equipment is like you've never seen it before. And so if you ask for a scalpel, like we had a nice scalpel today, but they give you a razor blade. Okay? And as a matter of fact, the razor blades are so dull, you have to break it to make it sharper. Do you understand? Okay. And then here I'm doing surgery in La Paz, the capital. And I don't, like I said, La Paz is the altitude